everyone. Myself, Dr. Ayush, PICU Fellow in AIMS Jodhpur. Today, I am going to present a very interesting case from Pediatric Intensive Care Unit, a case of severe chemical pneumonitis with exogenous lipoid pneumonia. That Master A, 4 years old boy, resident of Pali, admitted to us on 15th of May and discharged on 25th of August, total PICU stay of 3 months. Child was presented with the complaint of machine oil injection on 10th of May 2025, followed by the vomiting, 4 episode 5 days back, fever for 5 days, and breathing difficulty for 4 days. Vomiting was 3 to 4 episodes just after the injection, non-projectile, non-blood stained, containing undigested food particles. Fever was high grade, 2 to 3 spikes per day, no diurnal variation, and breathing difficulty in the form of subcostal intercostal retraction with increased respiratory rate. There is no history of oral ulcer, lip bleeding, drooling of saliva, no history of stridor cyanosis, no history of hemoptysis, feeding difficulty, abdominal pain, no history of seizure, no history of yellow discoloration of eyes. After 5 days of injection, child presented to the AIMS on 15th of May. Pre-AIMS treatment, child outside admitted and gastric lavage was done and received ceftriaxone, ondansetron, metronidazole. In triage, when child presented to us, appearance was normal, breathing was abnormal, and color was normal. That is classified as unstable and non-life threatening. Uh, Airway was clear. Child has a tachypnea with increased effort. Intercostal and subcostal retraction was there, and bilateral diffuse crept with 88% on saturation on room air. Circulation-wise, child was fine. Child has a GCS of 15 by 15 with pupil 2 reacted to the light. Child has a afebrile, no external injuries or bleeding. So classified as level 2 emergent respiratory failure, and started on the nasal prong at 2 liter per minute. After that, saturation was 95%. Anthropometry wise, child gain weight and height appropriate for age, and in general physical examination, there is a no pallor, icterus, cyanosis clubbing, lymphadenopathy, or no bleeding from lips and oral ulcer. In systemic examination, respiratory wise, child was tachypnic. On percussion, there is a dull note in axillary area bilaterally, and on auscultation, there is a crepitation in axillary area, bronchial breath sound in infraaxillary and axillary area, right side more than left side. Other systemic examination are within normal limit. When child was admitted in the ward, child was started on the amoxicillin with oral steroid prednisolone at 1 mg per kg, and respiratory distress wise, child initially put on nasal prong at 2 liter per minute, but after child was put on HFNC at 2 liter per kg because of persistent respiratory distress. X-ray in the ward was done, which was suggestive of bilateral opacity in all zones, but mainly in the middle and lower zones of the lung field. After that, child was shifted to the PICU on HFNC support, and oral prednisolone was continued, and budesonide was also started. On day 9 of illness, child developed tachypnea, tachycardia, saturation was decreased 8 to 89%, increased subcostal and intercostal retraction, decreased air entry in the right infraaxillary and inframammary area. And X-ray was done, which was suggestive of worsening from the previous X-ray. That is bilateral increase in the opacity in bilateral, middle and lower zones. So child was put on NIV 16 by 6 40% with OSI of 8 till day 20. On day 17, CT chest was done, which was suggestive of bilateral. There is a increased consolidation in middle and lower zone with there is a cystic lesion in the left side, suggestive of chemical pneumonitis. On day 20, child developed sudden onset tachypnea, tachycardia, saturation was 60%, increased subcostal intercostal retraction with bilateral decreased air entry. Focus of the lung was done, which was suggestive of this finding. Can anyone tell what is the finding? This is the barcode sign in the ultrasound, which was suggestive of bilateral pneumothorax. So child was intubated, ICDT was put and put on PSIV mode with a higher setting with a driving pressure of 15, P-plat of 25, compliance was 8, and OI was 29. In PICU, child has a persistent fever spikes with elevated CRP and PCT values of 289 and 2.45 respectively. Hemodynamically, renal wise and CNS wise, child was normal. During the PICU stay, child was continued on the enteral feed. During the course in the PICU, respiratory setting was gradually tapered, and on day 40, tracheostomy was done at setting of 12 by 7, 30%. For machine or chemical pneumonitis part, oral prednisolone was continued till day 50 and budesonide nebulization was continued till day 35. Child has a persistent recurrent bilateral pneumothorax. So for that, on day 47, bilateral pleurodesis was done. Tissue culture was sent after the pleurodesis, which was suggestive of MDR pseudomonas, which was intermediate sensitive to the colistin. During the course in the PICU, child grew multiple times Pseudomonas aeruginosa in ball culture, so that was treated as per sensitivity, and nebulized colistin was also given for 14 days. Because of the steroid, child developed hypertensive records, which were treated by antihypertensive. Renal wise and neurologically wise, child was normal. Because child has a persistent respiratory distress, child has a continuous high grade fever spikes, and child also had elevated CRP value and PCT value, and child had chemical pneumonitis part not resolved with the steroid. So CT again was repeated, which was in initial A and B image. There is a small cystic lesion in bilateral lung field, and in the C image there is a lipid attenuation in the left basal region of the lung, which was suggestive of exogenous lipid pneumonia. So bilateral partial lung lavage was done. After that, the sepsis marker and fever frequency has been decreased, and we are able to taper down the respiratory setting next 15 days. Ball fluid cytology was sent, which was paucicellular, so we are not able to stain the lipid content in the macrophages. This is the serial X-ray after the post-lung lavage. Initially, in day 5 post-lavage X-ray, there is a zones, but and lower zones gradually improved in day 20 X-ray, and there is a markedly improved in day 45 X-ray. Our index child in initial 40 days, first 40 days, there is a both CRP and PCT values was high. That was suggestive of increased inflammation with superadded infection. After that, PCT has came down, but CRP was still elevated, which was suggestive of active inflammation. After partially bilateral lung lavage, CRP value came. In the PICU, child has a persistent fever spikes. So after that, bilateral lung lavage, partially lung lavage, fever frequency has been decreased, and a child finally become febrile. Other issue which we faced during the treatment of this child was hypercalcemia, uh, which was related to PTH independent hypercalcemia, and we attributed it because of the lipid itself. So we treated with the hyperhydration 180% of fluid with Lasix, and also child was started on the prednisolone for 10 days and calcitonin for 14 days. After that, calcium value returned to the normal. Child also had UTI, and culture gave Enterococcus faecium, which was treated with the linezolid for 10 days. This is the Pseudomonas aeruginosa, which was grown in the ball multiple times, and sensitivity pattern is also there. In on investigation, child has a persistent neutrophilic leukocytosis with elevated CRP PCT value, which gradually settled down during the course in the PICU. As child was ventilated for prolonged duration and also received sedation in high dose for prolonged duration, so we implemented the ICU liberation bundle in our index child. That is A, access, prevent and manage pain. B, both spontaneous breathing and awakening trial. C, choice of analgesia and sedation. D, delirium screening and prevention of the treatment. E, early mobility and exercise. And F, family engagement. There are the following challenges we faced during the management. Child had persistent fever spikes with neutrophilic leukocytosis and elevated CRP, as we discussed. Child has a persistent pneumothorax, for which we did the bilateral pleurodosis. There is a persistent respiratory distress. Child had a malnutrition due to the critical illness and recurrent feeding intolerance. Initial admission weight was 15 kg, which came down to 10 kg. Child developed hypercalcemia, and child also had a ICU delirium. Child came on follow-up on 11th of November 2025 with vitals was stable. Child able to do the day-to-day activities, and current weight is 12 kg. Tracheostomy was removed 10 days back, and child had a on grade 2 clubbing with what pan digital. On examination, child has a mild subcostal retraction, intercostal retraction with bilateral air entry equal on. There is no added sound. Echo was done to rule out PEH. That so echo suggestive of there is no PEH. X-ray was done, which was suggestive of bilateral opacity is present, but clearing from the previous X-rays. And there is also there is a right side small air-filled bulla. Plan was to do pulmonary function test and CT chest to look for interstitial changes. This is the our index child. This is the condition. Just before the tracheostomy, child is ambulatory, able to do activities, playful, alert, neurologically normal. So coming to the our topic, that is the hydrocarbon ingestion, which uh, child is presented. This hydrocarbon ingestion was one of the most common accidental poisoning under the 5 years mainly, and it accounts for mainly 6% of the hospital admission. It is occur mainly in the domestic setting because of the stored in the unlabeled container and easy accessibility. Hydrocarbon comprise of kerosene, gasoline, turpentine oil, lamp oil, mineral oil. It is characterized by the low viscosity, low surface tension, high volatility, which facilitate this machine oil to deep into the pulmonary tissue, which causes chemical pneumonitis, finally surfactant disruption, epithelial disruption, and finally progress to necrotizing pneumonia or lipid pneumonia. There is a some mechanism of injury. Most common is aspiration into the lung, which leads to chemical pneumonitis and lipid pneumonia, which I told. There is a high viscosity, high volatility. That causes pulmonary surfactant disruption that impair the gas exchange. They disrupt the lung epithelial cell, which leads to lung abscess or necrotizing pneumonia, neurological symptom, and hypercalcemia. And hypercalcemia, it is a very uncommon symptom. Rarely we found in lipid pneumonia. It mechanism is there is a granuloma formation, and the macrophage in the granuloma produce ectopic calcitriol, which so that after more calcium is absorbed from the intestine, and this lead to the hypercalcemia. This is the same phenomena we observed in the other granulomatous disease like sarcoidosis and tuberculosis. Lipid pneumonia, this is because of the inhalation or aspiration of fat containing substance, as our index child aspirated the hydrocarbon, that machine oil, which is characterized by the accumulation of the lipid in the alveoli. This is the radiological progression. Initially, early phase, there is a ground glass opacity. After the 48 hours, there is a segmental consolidation. After the 2 week, there is a full fluid-filled pneumatocyst, and in 2 month, two or more than month, this leads to air-filled pneumatocyst. The complication is uh, persistent respiratory distress, pneumatocyst and abscess formation, and chronic lung damage. Treatment strategy, that initially we have to do the support, like for respiratory failure we have to do mechanically ventilate the child, and ECMO in life threatening hypoxemia. Antibiotic, we have to choose empirical coverage for the secondary bacterial infection, and after that we have to choose culture if pneumonia is complicating. And third is corticosteroid. This is the some study of the steroid use in the hydrocarbon ingestion. This is the low quality. There is no RCT available, only descriptive basis, and steroid duration also varies in different studies. So there is a lack of consensus. Therapeutic lavage we have to do in reserved for refractory or severe cases, that is not improving with the medical therapy. There are the some studies, systemic review and case studies, which in this study they did the bronchoalveolar lavage. In some cases there is an improvement, radiological improvement, clinical improvement, but there is a only descriptive, there is no RCT available. So take home message is aspiration of hydrocarbon causes chemical and lipid pneumonitis, surfactant disruption and direct cytotoxic effect. Steroid role is uncertain, weak evidence, no RCT, only descriptive basis study was there. Whole segment or lung lavage help refractory or persistent lipid pneumonia. Early airway protection, supportive ventilation, and culture guided antibiotic is crucial in the treatment part of hydrocarbon ingestion. So, thank you for today's class.